وصلنا طبعا بدينا بالcongenital abnormalities واخذنا البايلونايدال ساينوس، ووراها بدينا بالهيمورويد ووصلنا للcomplication of hemorrhoid. اوكي. اوكي. وبدأنا بالاناتومي، طبعا كلش مهم بالانوركتال ديزيز حتى نفتهمها لازم نعرف الانترنال سفنكتر والاكسترنال سفنكتر، الميوكوزا upper part of the anorectal mucosa، الدنتيت لاين اللي يقسم لنا الانال كانال الى upper 2 cm and lower 2 cm. اوكي. وابتدأنا بالبايلونايدال ساينس والهيمورويد. بالهيمورويد اخذنا الكوزز والكلينيكال فيتشر ووصلنا للكومبليكيشن اوف هيمورويد. بالكومبليكيشن طبعا تخلون ببالكم اكو كومبليكيشن اوف هيمورويدز واكو كومبليكيشن اوف ذا اوبريشن اوف هيمورويد اللي هي complication of hemorrhoidectomy. Complication of hemorrhoid include anemia following or continued bleeding. Of hemorrhoids are strangulated bile. It is one of the causes of thrombosis of piles. Strangulation when prolapse hemorrhoid crossed by external anal sphincter. This condition associated with severe pain and ulceration is another complication of hemorrhoid. Gangrene when strangulation is sufficient tight to occlude blood supply. Fibrosis and suppuration. Phlebitis. This is theoretical complication of hemorrhoid. It is rare. It is one of the causes of portal pyemia, but it is rare. The venous return is occluded and the thrombosis of the bile occurs. The prolapsed hemorrhoid are swollen, often to size of large lumps, purplish, black, and tense, and accompanied by considerable pain and distress. Suppurations and ulceration may occur. After 2 to 3 weeks, the thrombosed piles become fibrosed, often with spontaneous cure. This is complications of hemorrhoid. It is important. And the treatment of piles or hemorrhoid. Before commencing treatment, it is essential to exclude either any predisposing cause or any associated and more important lesion, carcinoma of the rectum and carcinoma of the colon, because sometimes the early presentation of carcinoma of the rectum is hemorrhoid. Conservative management. Ideally, the patient should avoid straining at the stool and aim to pass a firm, soft motion daily. Bulk laxative together with advice on adequate fluid intake are often required. إذن عندنا conservative treatment وعندنا surgical treatment بالهيمورويد, and we have to start with conservative treatment and constipated, should not also bleeding and pain. Painful hemorrhoid only if it is complicated. Sclerotherapy. This is suitable for first and second degree hemorrhoid. 2 to 3 ml or cc of 5% phenol in almond oil is injected. 5% phenol in almond oil should be injected to each bile, to the root of the bile, as a sclerosing agent or sclerosant in the submucous region in order to cause fibrosis. The phenol sterilizes the oil, which is the main sclerosant. Because the injection is placed high in the anal canal above the dentate line, 2 centimeters from anal verge, it is painless. 1 or more repeat injection may be required. يعني مرات جلسات نحتاج بالسكليروثيرابي may be required at monthly interval. Then conservative treatment, sclerotherapy, banding, application of small O-ring rubber band to areas of protruding mucosa, which falls away after a few days. It can be successfully applied to first and second degree bile, but care must be taken to position the band above the dentate line, يعني around the root of hemorrhoid. Least the patient should feel the application, not more than 2 hemorrhoid in 1 session interval, at least 3 weeks. إذن يعني مو أكثر من 2 hemorrhoids نسوي لهم banding by baron gun. والinterval should be at least 3 weeks. Cryosurgery is another method of treatment with the use of liquid nitrogen in some center, extreme cold, minus 196 centigrade, cause necrosis. This method has been abandoned because it causes troublesome mucus discharge and pain. لذلك it is stopped and prohibited cryosurgery. Photocoagulation is another method. Application of infrared coagulation. This method is effective and painless method, but needs a special instrument for infrared application. Okay, now we start with surgery and indications for surgery. The indication for surgical treatment, either 3rd degree hemorrhoid or 2nd degree hemorrhoid, which is not cured by non-operative methods. And 3rd fibrosed hemorrhoid should require surgical treatment, and internal-external hemorrhoid, when external hemorrhoid is well-defined technique. Then the indications for surgical treatment, 3rd degree, second, which is not cured by non-operative, or fibrosed hemorrhoid and internal-external hemorrhoid. And preoperative preparations for hemorrhoidectomy, laxative on the evening before operation, enema also to the anal canal should be shaved at morning of the operation. The rectum is evacuated with the aid of enema. These are preparation for hemorrhoidectomy. We have 2 types of operation. There is open method and closed method. Milligan-Morgan hemorrhoidectomy is a closed technique where the bile are excised and the wound should be left open, يعني healing by granulation tissue. Post-operative care, patient take 2 warm baths each day, give bulk laxative with appropriate analgesia, طبعا واكيد antibiotic لأن dirty area, and dry dressing are necessary. Patients seen after 3 to 4 weeks for rectal examination, and if there is any stenosis, you have to do dilatation, يعني by perirectal examination. Thrombosed strangulated piles, conservative management is instituted for these. The patient is placed in the bed with the foot of the bed elevated. يعني نرفع النهاية مال السرير. The patient بالthrombosed bile should be placed in the bed with the foot of the bed elevated. Opiate analgesia is given for severe pain, which is also eased by local cold compresses. Often the thrombosed biles fibrosed completely with spontaneous cure. Many surgeons now carry out hemorrhoidectomy on these patients with thrombosed bile. And then another option is hemorrhoidectomy and the special complication of hemorrhoidectomy. إذا هنا complication of hemorrhoidectomy. إحنا قلنا complication for hemorrhoid. إحنا لا complication of hemorrhoidectomy. Early complication, acute retention of urine due to acute anal discomfort post-operatively, and pain after operation of hemorrhoid, stricture formation. This is usually after few days or sometime weeks. This only occurs when excessive amount of mucosa and skin are excised. Sometimes patients with 3 major piles, external and internal hemorrhoid, and many internal hemorrhoid. So removal at hemorrhoidectomy of much mucosa may result in stricture. It is important to leave a bridge of epithelium between each excised hemorrhoid in order for healing by re-epithelialization. And post-operative hemorrhage, this may be reactionary usually on the night of the operation or secondary about the 7th or 8th day. Then important complication اللي هو post-operative bleeding and may be reactionary at the day of operation at night or secondary after 7 or 8 days. Bleeding may not be apparent externally, as the source of hemorrhage may be above the anal sphincter, with the blood filling the large bowel with the only little escaping to the exterior. General treatment comprises blood transfusion if hemorrhage is so severe. Then blood transfusion is indicated as evidenced by the general appearance of the patient. A pulse raised above 100 and a systolic blood pressure below 100, يعني tachycardia and hypotension, may be a complication of bleeding after hemorrhoidectomy. Local treatment is carried out under general anesthetic sometime in the operating theater, and the blood is washed out on the rectum with warm saline. Occasionally, a reactionary hemorrhage, a bleeding point is seen and can be diathermed. يعني نسوي diatherm من the bleeding point or ligated. More often, a general oozing from the operating field and the anal canal require packing with the gauze with a wide board rubber tube, which allows the evacuation of flatus and escape of any blood from the bowel. The tube and the gauze are removed after 48 hours. This is post-operative hemorrhage and its management. And late complication after hemorrhoidectomy, secondary hemorrhage, and stricture formation. This is only occur in excessive amounts of mucosa and the skin are excised. It is important to leave a bridge of epithelium between each excised hemorrhoid in order to let re-epithelialization and healing. Anal fissure may be complication after hemorrhoidectomy and incontinence when the sphincter is transected. It is very rare complication, but can present. Perianal hematoma, this lesion, which is also termed thrombosed external bile. Another name is 5 days limiting disease produced by thrombosis within inferior rectal venous plexus. Unlike internal hemorrhoids, it is covered by squamous epithelium supplied by somatic nerves and is therefore painful. The onset is acute often after straining at the stool with sudden pain and the appearance of a lump at the anal verge, and local examination shows tense, smooth, dark blue, cherry-sized lump at the anal margin. إذن البريانال هيماتوما أو بما يسمى thrombosed external bile العفو هي at the anal verge بتكون dark blue, cherry-sized, واضحة طبعا. It is painful condition. Untreated, the perianal hematoma either subside over a few days, usually 5 days, لذلك نسميها 5 days limiting disease, أو eventually leave a fibrous tag or rupture discharging some clotted blood. And the treatment of thrombosed external bile, in the acute phase, immediate relief is produced by evacuating the hematoma through a small incision. Immediate relief is produced by evacuating the hematoma through a small incision over the clot. لذلك performed under local anesthetic sometime in the our clinic. If the patient is seen and the hematoma is already discharging or become absorbed, hot bath and prescribed and reassurance give that all will soon be well. يعني ممكن تكون treatment conservative. نعطيه analgesia, antibiotic and hot baths, and sometimes decrease and subside and pain off. Otherwise, surgical removal of hematoma by incision over the external thrombosed external bile or perianal hematoma. Okay, at the end of hemorrhoidectomy, we start with another important surgical disease related to the anus and anal canal, fissure in anus, which is painful anal condition. Fissure is elongated tear at the anal margin with long axis of the lower anal canal, which usually follows the passage of constipated stool. Big fissure in anus. Constipation usually is constant. Constipation may end in fissure in anus, or fissure will end in constipation. يعني one is a cause of another. The site is usually site in anus is posterior in the midline. 90% of men and 70% of women. It is posterior in the anal canal from anal verge and ascend above. 90% in male and 70% in women. Occasionally, anteriorly in the midline, and rarely multiple fissure in anus, especially in inflammatory bowel disease like Crohn's disease. The posterior position of the majority of fissure is not well understood, but may be explained by the anatomical arrangement of external anal sphincter. It is superficial fibers. Its superficial fibers passes forward to the anal canal from the coccyx, leaving a relatively unsupported V posteriorly. Recently found by Doppler study is that the fissure due to ischemia, and the anterior fissures of female may be associated with the weakening of the perianal floor following tears at childbirth. Multiple fissures may complicate Crohn's disease of the colon. Crohn's disease can occur at any part of the GIT, but when it occurs and complicates the colon and the rectum, so the presentation may be fissure in anus. In this case, the fissure is secondary to Crohn's disease. Some causes of anal fissure are certain. First, due to incorrect performed hemorrhoid operation. يعني fissure may be complication of hemorrhoidectomy. Inflammatory bowel disease like ulcerative colitis and Crohn's disease, and maybe presentation of sexually transmitted disease. The clinical feature of fissure in anus more common in female, especially in the meridian life. It is uncommon in elderly. Why? طبعا because of the laxity of the muscles and the tissue. It is not rare in children and one of the causes of constipation in children is fissure in anal. And the types of fissure in anal, either acute or chronic fissure in anal. And acute anal pain is characteristic. It is sharp, agonizing pain started during defecation, lasts for 1 hour or more later. Fissure is the commonest cause of pain at the anal verge. Then, fissure is the commonest cause of pain at the anal verge. مثل ما الهيمورويد معروفة بالبليدنج as a cause of bleeding per rectum. طبعا bleeding per rectum also presentation of CA rectum and colon. Fissure معروف بالpain, painful anal condition. There is often slight bleeding and because of the pain the patient constipated. طبعا قلنا الpain ممكن may cause constipation and constipation may cause fissure and discharge, slight anal discharge. In a chronic type characterized by an inflamed indurate margin and base consisting of either scar tissue or the lower border of the internal sphincter muscle. It is associated with a skin type called sentinel bile. On examination, the anal sphincter is in spasm, spastic anal sphincter with anal fissure, especially in acute fissure, and there may be a sentinel bile or skin tag producing from the anus, which represents the torn tag of anal epithelium, and the fissure can usually be seen by gently pulling open the anal verge. طبعا موجود خصوصا بالميال نشوفه posterior بالفيميال والدليل انه نشوف skin tag وياه وطبعا painful. It may be impossible to do rectal examination without anesthetic يعني xylocaine gel نخليله and even that the fissure may then be palpable as crack in the anal canal. It is usually posterior but rarely occur anterior, especially in female. Differential diagnosis of fissure in anal, carcinoma of the anus in early stages, especially ulcerative type. If there is doubt, must be excisional biopsy should be done. يعني you have to remove the fissure and send for histopathological examination. Multiple anal fissure may be associated with skin disease and AIDS. يعني acquired immunodeficiency syndrome may be associated with anal fissure and cutaneous disease, tuberculous ulcer of the anal canal with undermined edge, and proctalgia fugax. The proctalgia fugax, painful anal condition, occurs especially in doctors. هو differential diagnosis also with anal fissure. And treatment, early small fissures may heal spontaneously. يعني laxative and even simple analgesia because it is painful. لذلك early small fissure may heal spontaneously, especially if it is acute. A local anesthetic ointment together with lubricant laxative may give relief. Application of glyceryl trinitrate cream relax the anal sphincter and allowing the torn epithelium to heal. More intractable cases usually respond to dividing the internal anal sphincter submucosal under general anesthesia. يعني نسوي له lateral sphincterotomy, sometimes posterior sphincterotomy and excision of the skin tag. It is important to assess and treat fissure. You have to assess the anal tone prior to perform a sphincterotomy. And one method of treating fissure in anal is by dilatation. as incontinence may result, particularly in patients who have suffered previous obstetrical injury. Then, treatment of sphincter, treatment of fissure in anal may end with incontinence, but it is very, very rare. It is for the same reason that an anal stretch is now seldom performed. The anal dilatation nowadays, it is minimized, but we have to use lateral sphincterotomy. A newer alternative is a chemical sphincterotomy using injection of botulinum toxin, اللي هو البوتوكس, into the internal sphincter. This has advantage that the sphincter paralyze, يعني راح يعطينا relaxation. It's short-lived but give more sustained effective than glyceryl trinitrate cream. And operative procedures for fissure in anal, gentle dilatation of the sphincter under general anesthesia. Careful with those with weak muscle sphincter. إذن anal dilatation أو Lord's dilatation طبعا نستخدمها أقل ما يمكن لأن واحدة من complication همه اللي هي incontinence. Lateral anal sphincterotomy, healing usually within 3 weeks, and operation more successful in acute than chronic. Fissure and anal advancement flap more popular because of incontinence is unlikely in anal fissure management. At the end of anal fissure, we start with anorectal abscesses. Anorectal abscesses common, and it is emergency cases. Causative agent is 60% E. coli, 23% Staph aureus. In many cases, the infection is mixed, and the clinical features of anorectal abscess producing painful throbbing, swelling in the anal region with swinging pyrexia. طبعا collection of pus أكيد راح يكون عندنا pyrexia وممكن يكون tachycardia, throbbing pain at the anal region. Types of anorectal abscesses. The commonest is 60% of the cases and result from infection of hair follicle or sebaceous gland or perianal hematoma. It causes perianal abscess. It lies in the subcutaneous portion of external anal sphincter. It affects all age group. The second common type is ischiorectal. Ischiorectal, 30%. Submucous, 5%. And pelvirectal, also 5%. Submucous, 5% to occur above the dentate line. احنا قلنا البريانال is common 60%. Submucous بالmucosa above the dentate line, it is 5%. Infected fissure or laceration of the anal canal as by fishbone or bloodborne after injection of hemorrhoid. And ischiorectal, 30% from infection of anal gland leading from the anal canal into the submucosa. Spread of infection of the perianal abscess or penetration of the ischiorectal fossa by a foreign body, rarely due to lymphatic or bloodborne. The abscess may track as a horseshoe behind the rectum to the opposite ischiorectal fossa via the posterior sphincteric space. إذن صار عندنا perianal, ischiorectal 30%, submucous 5%, and pelvirectal 5% also. أو أقل, it is rare, situated between upper surface of the levator ani and pelvic peritoneum. It is pelvic abscess because it is above levator ani muscle. It is rare and usually secondary to appendicitis or salpingitis and diverticulitis. And the treatment, for treatment of anorectal abscess, early surgical drainage to prevent rupture and possible formation of fistula and ano. إذا عندنا anorectal abscess, you have to treat it as early as possible in order to prevent complication اللي هي fistula and ano. Antibiotic has no major role because the area poor blood supply and concentration of antibiotic not reach the maximum concentration. So the drain important, the drainage, sorry. لذلك you have to do incision and drainage of the abscess and under the cover of antibiotic. After that, we start with fistula and ano. Fistula and ano, by definition, fistula is abnormal communication between two epithelial surfaces, example, between two hollow viscous, or between hollow viscous and surface of the body, or between two hollow viscera. A sinus is a granulating tract lead from the source of infection to the source. تعرفون الفرق بالثيرد يير أخذتوا شنو definition of fistula, definition of a sinus. Fistula in ano, it is a tract lined by granulation tissue that connect deeply in the anal canal or the rectum and superficial to the skin around the anus. مهمة. Fistula in ano is common anal and anorectal pathology. And etiology of fistula in ano. The term fistula in ano is loosely applied to both fistulae and sinuses in relation to the anal canal. The great majority result from an initial anorectal abscess with spontaneous burst or rupture or inadequate opened and evacuation. Then, fistula in ano may be a complication of perianal abscess, a growth of organism as opposed to the skin flora from anorectal abscess, suggestive of the presence of a fistula. Rarely the fistulae are associated with the Crohn's disease and ulcerative colitis and carcinoma of the rectum, occasionally also tuberculosis. Then fistula of ano may be specific due to carcinoma or tuberculosis, or fistula in ano may be a complication of inflammatory bowel disease like Crohn's disease. Anatomical classification of fistula in ano is divided into two groups according to whether internal opening above or below anorectal ring. So standard classification مهم. عندنا Park classification بالفistula in ano and standard classification. The standard classification, fistula in ano is classified into subcutaneous, submucous, low anal, high anal, and pelvirectal, while Park's classification either intersphincteric or transsphincteric, which is either high or low, or supralevator. مهم. Good Saul's rule: if a transverse line is drawn across the anal verge, an external anal fistulous opening anterior to this line will lead directly to the rectal lumen in the straight radial pattern. However, external opening posterior to this line will lead to curved pattern to the posterior midline of the rectal lumen. تفسيرها شنو؟ تفسير الجود سولز rule انه البيشنت بالليثوتومي بوزيشن نخلي ترانسفيرس لاين بالانال كانال. اذا عندنا اوريفيس للفستولا ان انو انتيريور بالليثوتومي يعني above the transverse line معناها هي direct. بينما اذا كانت posterior يعني below the line posterior فمعناها انه الفستولا راح تكون curved pattern. هذا هو الجود سولز rule. And the clinical features of fistula in ano, there is usually a story of initial anorectal abscess which discharge pus Following this, there is recurrent episodes of perianal infection with persistent discharge of pus. Pain is not a symptom unless abscess formation due to occluded external opening. Sometimes we see multiple openings, but usually on the same side. But if contralateral schizorectal fossa involved, we may see opening on the either sides. Then could be one orifice, could be multiple orifices. وطبعا sometime one orifice, sometime multiple orifices. And examination reveals the external opening of the fistula. The internal opening may be felt by rectal examination. يعني by inspection إنه نشوف external orifice. بينما internal orifice ممكن نتحسسه by rectal examination or during proctoscopy. But probing of the tract is painful, be deferred until the patient is anesthetized. يعني ما نستخدم البروب والpatient without anesthesia because this may cause pain and may reawake dormant infection. Accurate assessment of the extent of the fistula tract, in particular, its relation to the anal sphincter is crucial. طبعا مهم نحدد إنه الفistula is it low type or high type. It is important because management of high fistula without determining that it is high fistula or low fistula, it may end in incontinence by transecting the anal sphincter. لذلك الهاي fistula not treated by transecting by the usual method of use low fistula and anal. When doubt exists, endo-anal ultrasound or MRI can be demonstrate the anatomy of the fistula. Very important. إحنا the distance من الانال verge 1 inch يعني 2.5 centimeter and above, it may be high fistula. If it is less, may be low fistula. Special clinical types of fistula and anal. Fistula connected with anal fissure. In this type, the fistula pain is the main symptom because the fissure is painful condition. It's very near the anal orifice and usually posterior. And then fistula and anal may be connected with fissure in anal. Fistula and anal may be associated with perianal abscess. Fistula and anal may be associated with hemorrhoid. A granulomatous infection like tuberculosis and Crohn's disease may be associated with fistula and anal, and carcinoma arising with perianal fistula, يعني maybe anal canal carcinoma or rectal carcinoma may be associated with fistula and anal. لذلك fistula and anal may be a special type of tuberculosis or Crohn's disease or carcinoma. It may be associated with foreign body also. And the treatment of fistula and anal, preoperative preparation, enema, finding of internal opening is crucial because there is difference between low fistula and anal and high fistula and anal. By manual digital examination and retrograde probing, patient should be anesthetized, or by proctoscopy. ندخل proctoscope ونلاحظ internal orifice and injection of methylene blue or dilated hydrogen peroxide. All these important to determine the internal orifice and to determine whether it is low or high fistula and anal. And superficial and low-level anal fistulae, are late opened and allowed to heal by granulation. يعني نسوي له fistulotomy أو fistulectomy. هاي بالsuperficial and low type anal fistula because no sphincter or only the subcutaneous part of external anal sphincter. Internal sphincter is divided. In this procedure, there is no loss of anal continence. يعني below fistula and anal, we can treat it with a trust and no injury to the internal anal sphincter. So there is no incontinence. Fistula can only be treated in this manner when they quite lie below the level of anorectal ring, that's to say, low anal fistula. In high fistula and anal, which is either suprasphincteric and transsphincteric, close to anorectal ring, only the lower part of the fistula is left open. If it is high fistula and anal, you have to do fistulotomy to the lower part, or fistulectomy to the lower part of the fistula. An unabsorbable strong ligature like nylon or silk material termed satin is passed through the upper part of the tract and left in place for 2 or 3 weeks, sometime 1 month, so that the sphincter is fixed by scar tissue. يعني نشيل نرفع نسوي excision للlower portion of the high fistula and anal, الupper part ندخل بيه satin ونسوي discharge للبيشنت، وطبعا يظل يسحب عليها كل ما يروح للWC، وتبقى هاي القضية 3 weeks to 1 month in order to keep the sphincter healed and prevent incontinence, or by repeated tightening of the ligature lying open the whole tract of the suprasphincter fistula in order completely divide, in order to prevent complete division of the sphincter and result in continence. يعني ممكن إنه repeated tighten حتى يقص بالupper part of the sphincter، يقص ويصير healing above it، يقص downward و healing above it in order to prevent incontinence. Okay, stricture of the anal canal. Classification is either congenital stricture at the level of the anal valve due to incomplete obliteration of proctodium, يعني proctodial membrane, or spasmodic, like spastic stricture, like in anal fissure, or organic stricture. Post-operative also occur, usually after 2 radical excision of skin and mucosa after hemorrhoidectomy, and inflammatory stricture like lymphogranuloma inguinale, post-irradiation, or infiltrating neoplasm. All these are types or causes of anal stricture. Endometriosis and rectovaginal septum may present as a stricture, and the clinical features increasing difficulty in defecation. Clinical feature of anal stricture, increasing difficulty in defecation. It is one of the causes of constipation, but in cases of inflammatory stricture, tenesmus and bleeding and passage of mucus and sometimes blood may be a feature. And treatment depends on underlying pathology and may call for repeated dilatation by plastic reconstruction or defunctioning colostomy أو بوجيز. يعني ممكن نستخدم dilatation, repeated dilatation by bougies, or plastic reconstruction, or sometimes defunctioning colostomy, especially for high-type fistula and anal, or in cases of malignant disease, excision of the rectum, يعني radical excision of anal canal or the rectum, a resection of the rectum. This is the treatment. And malignant tumor, this is the last in this lecture. Carcinoma of the anus differ from carcinoma of the rectum in histological structure, behavior, and type of treatment. This because it is sensitive and abundant lymphatic drainage, both superficial and deep inguinal lymph nodes. 70% of anal tumor arise in the anal canal. 30% in the squamous epithelium or squamous cell carcinoma. 70% arise in the anal canal. يعني بالanal canal اللي هي above dentate line or below. But 30% squamous cell carcinoma تقريبا قريبة على anal verge squamous cell carcinoma. Because of its situation superficial, so the lesion recognized by the patient. So if the present early, but there is some exceptions. لذلك البرزنتيشن مو مثل CA rectum. It is early, especially if it is at the anal verge. There are some exceptions for the carcinoma. Anal warts sometimes take a carcinomatous lesion, more common in human immunodeficiency virus positive patient, and occasional squamous cell carcinoma develop a long-standing fistula in anal. Other tumors that occur in the anal canal is melanoma, and melanoma of the anus present bluish black soft mass which may confuse with thrombotic bile, and lymphoma also can occur. Then tumors of the anal canal could be squamous cell carcinoma, could be melanoma, could be columnar epithelium also can be affected with carcinoma and melanoma and lymphoma. Thank you very much.